Now we'll have the third presenter, Dr. Vishal Popthani from UN Mehta Hospital, Ahmedabad.
Good afternoon, respected chairpersons and dear friends. I'm presenting a case of an undilating thrombus. Should be treated as a friend or a foe. A 42-year-old male patient, smoker, non-hypertensive, non-diabetic, with no significant family history of any cardiac disease, and had history of recent anterior-wall myocardial infarction. A week prior to hospitalization, he was non-thrombolized. He came from a very peripheral center. Hemodynamically was stable. ECG had evolved anterior-wall MI. Echocardiography showed anterior-wall regional wall motion abnormality with LV ejection fraction of 35% and moderate mitral regurgitation. The coronary angiogram revealed normal right and left and circumflex systems. LAD was totally occluded from its origin. With informed consent, patient was taken up for PTCA with upstream GP2B3 inhibitor and heparin, 100 units per kg body weight. Following are the sequence of events which unfolded thereafter. This is the coronary angiogram. LAD flush occlusion, a big high OM or ramus with circumflex system. We parked in with a passed the whisper hydrophilic wire which crossed easily. This was followed by runs of Diversey, the thrombosuction device. This was repeated. We almost repeated 4 to 5 times the thrombosuction in the left anterior descending artery. No flow was established. We again checked it in an orthogonal view. Then we decided to do a balloon with a 2.5 by 12 millimeter balloon. We inflated the balloon there. And this was the picture which happened thereafter. The thrombus proximally migrated into a distal left main, totally occluded the high OM branch, also migrated into the left circumflex system. At this point, patient started having chest discomfort. Hemodynamically, he was stable with the pressures of 120. He started sinking. We immediately took in a park in another wire. At that point of time, while taking the blood back out of the tuibos, there was no back bleed which we could get. We thought probably there was a thrombus which was there in the guiding catheter. We immediately removed the whole system and then again recrossed. Recrossed with the high OM branch, did Diversey runs there first. At this point of time, the left groin was also being prepared for putting in an IBP insertion. We did 8 runs in this ramus intermedius branch, and thereafter this flow established. We parked in another wire into the circumflex, did Diversey run there. Meanwhile, the balloon pump which was ready, we put in the balloon pump at the same time. Did Diversey runs, and after the establishment of the flow in the high OM as well as the OM branch, we proceeded with the left anterior system. We did thrombosuction there itself. Again, we had to do the thrombosuction for almost 5 times. And this is how the flow was established. Again, there was a thrombus which was there in the distal LAD. And then after doing the Diversey run there also, the final angiogram which we could see. There was a residual thrombus in the distal diagonal which we kept for the medical management. So to conclude, I would say meticulous thrombosuction is a must. A large thrombus burden artery, osteal location, and non-thrombolized patient should be watched for above complications as in our patient. Young patients can do away with just thrombosuction only, and the foremost need was to maintain composure by the operator during such complications, which is the key. The patient was further investigated for evaluation of risk factors. He was found to have hyperhomocystinemia as well as vitamin B12 deficiency and has been put on corrective therapy for that. This is a follow-up of 1.5 months. He is doing fine. no chest discomfort. There was an immediate stunning effect. The LV ejection fraction post-procedure was 35, but thereafter it has improved to 45 presently. Thank you.
So this is most important, especially near osteoproximal LED thrombotic occlusions. Always you should take a thrombosuction very adequately before dilating, because we use more commonly the G balloons. In that folds, the thrombus will become cart hold, and while removing, the importance of maneuvers you have to do. Either you have to give contrast injections so that the thrombus won't be dislodged backwards into left main as well as into circumflex. In some operators, sometimes they put these filter devices in the circumflex, especially near osteoproximal thrombotic occlusions. Very important. You should anticipate this problem, especially acute osteoproximal thrombotic LED occlusions. These complications occasionally every operator will get. So mostly these are all preventable by anticipating and taking the precautions while doing. So don't do balloon dilatation, especially with G balloon. This is very important comment in this patient.
Right. Sir.
So what was the window period for this patient?
So the window period was 4 days. The patient had anterior wall infarction 4 days prior to the hospitalization in our institute.
Right. So did he have an angina after the...
So he had post-infarct angina. That is why he was referred to our institute, sir.
Yeah. Did we show any collaterals in the lady
so there were no collaterals. I have not shown it from the RC angiogram. There was no collaterals which were there which had...
So should we have done a myocardial viability 4 days post-MI, LED totally occluded? We have not shown a collateral. Should we have done a viability before going ahead with a PCI?
So in the presence of LV ejection fraction of 35%, there was regional wall motion which was still there. There was no akinetic segments on echo which could be demonstrated. And in the setting of post-infarct angina and patient being non-thrombolized, this is how we treated it.
Right.
Thanks, Vishal.